Camry we've got whilst the meeting's in progress, and at the end of the meeting I'll invite you to ask any questions about the meeting, so if that's all right. So welcome everyone. I want to make some remarks just at the beginning of the meeting before we get started relating to the death of Her Majesty. We all heard of the news of the death of Her Majesty with great sadness. Her reign encompassed difficult years after the Second World War and the early beginnings of the NHS right up to the present day. And her award of the George Cross to the NHS, I think, is a symbol of the high regard she held for those working in the service. I know we'd wish to record our condolences to the King and the royal family on their loss, and also to wish the King well as he takes on his new role as head of state. And as a mark of respect, I'd ask that we observe a minute's silence before the meeting. Thank you very much, everyone. We'll now start the meeting formally. So welcome to everyone, welcome to our observers, welcome to our guests. I think there were no questions from the public submitted in advance. Apologies we have from Naomi Coxwell. I think that's all, Julie.
Yes, it is.
So any declarations of any other business for the meeting? Declarations of interest in the register or the agenda? So the minutes of the meeting of the 12th of July, any corrections, please? No. Action log and matters arising? Okay, so let's move on to what I think is going to be an interesting session. The patient story, Children's Specialist Services, and Debbie, I'll hand over to you to introduce the team and the topic.
Thank you, Martin. Yeah, this will be very quick and then I shall hand over to Hannah. But I think we've got Hannah, Amanda, Helen and Justine all going to do a little bit of the next few minutes of story. I do want to say, this is children's community nursing, and these staff deal with our most complex, poorly and end-of-life children. So I think Hannah would say this might come with a bit of a health warning. The story that you're going to hear this morning. But on that note, thank you all ever so much for coming along to share the story. And I'm going to hand over, and I think Hannah has got some slides to share as well. And she knows it's 10-ish minutes, might be slightly longer, a couple of minutes longer, and then some time for questions.
Thank you very much, Debbie. Welcome, Hannah.
Thank you very much. Can you see the slides?
We can.
Brilliant. Okay, hi. Yes, thank you, Debbie, for the introduction, and thanks for the bit of the warning. I was going to give that, but you've done it. So end of life is a difficult subject at any time, but particularly for children. So if people don't feel comfortable, then please join back in about 15 minutes. So my name is Hannah Ryman. I'm Head of Specialist Children's Services, which sits within the Children, Young People and Families Division of BHFT. And within Specialist Children's Services are the community paediatricians in the East, the community children's nurses and special school nurses in the East with the respite service, the special school nursing in the West, the community children's nursing in the West, which is the team, part of the team I'm with today, and the community dietitian. So that gives a bit of context. And I'm going to let my colleagues introduce themselves.
Hi, I'm Amanda Ronchetti. I'm one of the children's community nurses, and I take the lead in end of life and palliative care and the rapid response.
Hi, I'm Justine Turner. I'm also a children's community nurse, but I take a lead on transition and long-term ventilation.
Hi, I'm Helen Gray, community children's nurse, and I take the lead for oncology.
So I'm going to whiz through the first few slides because I think it would be great to hear from the staff who are actually doing the care in the home. And these are 3 senior CCNs within the West team. They're made up of a team of 9 altogether with about 6.8 whole-time equivalents. So they're a relatively small team doing a huge amount of work in a brilliant way. So there's the introduction. So we'll carry on. So here's the aims of the service. I'll let you read that while I discuss how the CCN West team came over to BHFT. They were TP'd over from the RBH, Royal Berkshire Hospital, in October 2019, just before COVID hit. So it's been an interesting time for them. They've had a lot of service development. We went to 8 to 8 provision from 9 to 4. They also cover bank holidays. And as I said, there's been a lot of redesign and redevelopment. They've also had the challenge of COVID. This team has worked business as usual during COVID, obviously with the adaptations of PPE and protecting vulnerable children, but they're an essential service and have continued as usual. The other element that we're going to talk about today is the end of life pathway. This is formally commissioned in the West. It's not formally commissioned, in the East. It's not formally commissioned in the West, but we still do the same principles, working with our local hospices and multidisciplinary team to ensure that the end of life experience for the child and the family can be as good as it can be at a very difficult time. A couple of the other developments have been the rapid response service, which is when an unexpected child death occurs in the community, and the nurses in this team accompany the police to the home in a way of supporting the police and supporting the family, and they often end up as key workers. So I shall move on. I'm not going to go through these, but this just gives you an example of the variety of children that they see in order to meet the aims of the service to keep children out of hospital. It can be anything from a wound dressing to very complex children on ventilators, and of course the complexity of end-of-life care as well. This is just a diagram to show the multi-agency, multidisciplinary working that the team do in order to provide this wraparound care for the children and families, ensuring that everyone is working together. And these nurses often work as the key worker for the child, ensuring that all those agencies are working together and providing the best care they can. So let's move on to the patient journey. So the reason we've chosen this, it's been a very big challenge over the last particularly the first 6 months of this year. So child death is not a common occurrence. Since the 1980s, treatment and technological advances mean that the child death rate has decreased significantly. It's plateaued at the moment, but unfortunately, sadly, children do sometimes die. And this year has been unusual in that we've had 10 deaths in the first 6 months of the year. And as you can see from the slide, 3 of those were rapid response call-outs, unexpected death at home, where the CCNs accompanied and supported the family. 1 was in a hospice. This was a child who was an adolescent child and was in our local adult hospice because they provide for 16 plus. 1 child on our caseload sadly died during their sleep, and then 5 planned end-of-life home provisions, which we're going to talk about in a generalised way today. So I'm going to hand over to Amanda.
Hi, I'm going to speak about the process we take from the referral of a patient at end of life care to bringing them home. So the process of bringing a child home often happens quite quickly. We have to facilitate a move from hospital to home within a couple of hours to a couple of days. Normally we haven't got a long time frame as the children do deteriorate quite quickly at the end of life stages. To make this happen, we have a long list of checks that we have to complete to ensure a safe discharge. Before we can agree to bring a child home, we have to make sure we've got a rota in place to provide for at least 5 days, 24/7 care. So the team work together to get a rota. We don't just facilitate ourselves, we also work alongside the local hospice to ensure our rota is fully covered. Once the rota is fully covered, we can then inform the hospital that we can bring the child home. The hospital needs to provide the child with certain documents to make it safe for them to come home. The child needs to have an advanced care plan. An advanced care plan is a document that's created with the family and sometimes the child if it's appropriate. And this informs health professionals their resuscitation status. Normally it's a do not resuscitate, hence the end of life status. This needs to be distributed to the local hospital, the GPs, the out of hours GPs, and that's the role of the community nurse to make sure everyone knows about the ACP before coming home. The child also needs to have a symptom management plan. A symptom management plan is a document that the doctors address other symptoms such as nausea, pain, vomiting and constipation and breathlessness and how it can be managed at home, and make an escalation plan of medication. The CCNs have to inform the child's GP, the out of hours GP, the local hospital and the lead consultant on the local hospital that we've got a child coming home at end of life stages. We may need to organise equipment such as oxygen, pressure reliever mattresses, hospital beds, commodes such as suction machines, nebulizers and other equipment that cannot be travelled with the child or nor at the child's home ready. At this stage, we'll make contact with the parents to introduce ourselves and the service we are providing for them. This, of course, is a very difficult conversation. We have to remain professional but also compassionate, as we're about to take part in the most daunting experience the family and the child will probably go through in their lifetime. This service is not only provided for children who are already on our caseload, but any child who wants to come home to die in the West Berkshire area. This will have to be a quick referral process to get them onto our caseload for us to accept them to come home. 2 out of the 5 children that we facilitated to have their final moments at home were not known to our service prior to the end of life status. Once all the above is in place, all healthcare professionals are satisfied the child can come home. We have to arrange ambulance transport to get the child home. This is a very critical time in the child's short life due to sustaining medicines and equipment might be turned off prior to the discharge home. This makes the transfer home a very high risk procedure, as a child is at high risk of passing away in the transit. 2 CCNs will be at the child's home when the ambulance arrives to welcome them home. And then Justine will explain what we do when we're at home.
So, hi. Once the family and the child have voiced their wishes to have a peaceful death at home, the plans start to facilitate. The CCNs will carry out an initial visit when the child arrives home and then visit daily in pairs, as well as take telephone calls and carry out unplanned visits both day and night to offer support and review the child's changing condition. The CCNs may visit with a member of the hospice team or palliative care consultants to review the child and make any adjustments to planned care. At the first visit, the CCN's role is to ensure that everything is available to ensure the child is comfortable and that family are aware of all that may be ahead in their final hours, days or weeks. The role of the CCN is to be empathetic, supportive, provide information to support the family throughout this journey. At times, particularly when symptoms are hard to manage, the family can become distressed, but by building a rapport and using excellent communication skills, the situation can remain calm. The CCN teamwork alongside many other teams, including palliative care teams, hospices and tertiary hospitals. This also involves excellent communication to liaise and share information. The CCN is adaptable at each discharge to ensure a smooth discharge home, and ultimate aim is for a peaceful death is carried out. But by updating the multidisciplinary teams each day and at times when symptoms can change to ensure anticipatory measures can be coordinated and the child can be kept comfortable. Every family has a different experience to go through, and by showing compassion, being honest, building a rapport and listening and providing information, we can help the families through their journey. Part of the CCN role is to assess the child's symptoms and to ensure they remain pain-free and comfortable. There are many distressing symptoms apart from pain, ranging from agitation, respiratory distress to seizures. An in-depth, robust symptom management plan could facilitate managing distressing symptoms and support this period of time, although this plan can be changed at any time to meet the needs of the child. The plan will support the administration of all medications, including oral, central lines, subcuts, and patches. We also include distraction techniques and therapeutic measures to calm and provide optimum quality family time together. A challenge we currently have as a team is that we do not have a designated doctor in palliative care. By spending time with families and talking and listening, the support that families require to help understand their fears and worries can be evaluated and supported emotionally. The expertise of our nursing team to give empathy and compassion during this journey to the families is distinct, and a resilience in our team to overcome each individual incident has built over the last year. And now I'm going to hand over to Helen.
Thank you, Justine. Our experience over the last year has shown that each child's death has been different, requiring an adaptable approach by the CCN to ensure that the child and family's needs and wishes are met. Once the child has sadly passed away, our role varies to support the family at such a difficult time. We provide practical support where we'll help the family to make memories such as handprints and casts, and help to wash and dress the child or young person. We may arrange spiritual support, such as arranging for a religious leader to be present to support the family's spiritual beliefs. Some families may choose for their child to stay at home for a few days after they have died, and this is something we can support by setting up a cold cot in the family home, providing daily support visits until the child is taken to the undertakers. There is a considerable amount of liaison and coordination required to ensure that the process is smooth for the family at such a distressing time. The child's doctor will be contacted to ensure that the death is certified and verified, as is a legal requirement. We will then contact the undertaker to make the required arrangements. We contact the professionals and organisations in the child's care to inform them of the child's death. This includes the Child Death Overview Panel to prevent any unnecessary investigations into the expected death. A considerable part of our role is to provide bereavement and grief support for the family during such a difficult time. In the weeks following the child's death, we remain in contact with the family, offering further support and attendance at the child's funeral. We visit the child's family, offering further bereavement support and signposting specialist bereavement services for the family, including siblings. The support and input provided is tailored to suit the family's needs, and we often stay in regular contact with the family for a few months or weeks, depending on their needs of the family, and then we make contact on birthday and anniversaries. The family really appreciate this support as we've cared for them through the child's journey, for them being unwell to sadly passing away, knowing the struggles and journey that the family have been through. I'll hand over to Hannah.
Thank you. So I think, Deborah, we're probably nearly out of time, so I'll whiz through the last few. We have very robust debrief sessions through after a child's passed away with all the disciplines and agencies involved, and that has led, that's been a very useful tool to ensure that we make the experience better and better as we get more and more experience. So there are some examples. The next steps are looking at verification of death for the training for the nurses, rather than bringing in possibly a GP on call who the family have never met before at a very distressing time. And we're also looking at developing our end-of-life expertise within the team and formal bereavement training. Challenges. So this team provide this 24-hour rota voluntarily. So it is a challenge, particularly if you have 5 very close together, because the team are also doing their day-to-day caseload and then going on to a 24-hour rota. And that is a challenge, particularly if help from the local hospices is limited. And medical cover, which Justine mentioned, we are looking at managed clinical network across the Berkshire region. It's being organised, looked at by Bob, but will include East Berkshire as well. And that is to provide specialist palliative care provision for medical cover, as well as some clinical nurse specialists working. And I'll just leave you with a couple of bits of feedback to read. So I've included feedback from different agencies. We have a lot from parents and families, but there's a bit of a mixture. So I'll give you a second to read that. So you can see that even though it's been a huge challenge for the team, particularly the first 6 months of this year, the team have risen above and beyond the challenge set to them, and they are a remarkable team. So I'm very proud to manage them. Thank you. Any questions?
Hannah, could I just say something before I invite questions? This is fantastic, and I'm most grateful, as we all are, for the work you and your team do. It must be something that requires immense judgment and care in the way you discharge your responsibility to the patient. So just absolutely thank you very much for all you're doing. We've got some questions, not unsurprisingly. Aileen.
Hi, I can just echo what Martin said. Amazing service, and what incredible thing that you do for the child and for their family. I am in absolute awe of that service you're providing, and can only imagine you just make the most marvelous difference to what is a completely awful, terrible time for the families. It makes me feel actually quite emotional, and so, like you said with the health warning, I'm in awe of you. One question I had was, you talked about the family and the child making the choice. I wondered if you could talk a little bit more about making that choice about either leaving the hospital or the hospice to come home. How are you involved in that, and how is that handled?
Yes, do chip in. So it varies from child to child. So we've had one case where the family were asked not to take their child home because the child was symptoms were so unstable, and they discharged themselves to the home. So that was a challenge, and it happened very quickly. And the local hospice in Oxford and our team facilitated that discharge because the parents were going to take that child home, whether the advice from the hospital was stay or not. So, but actually, things moved very quickly, didn't they? And they facilitated the child with the wishes of the parent. There is a problem with choice in that we have 2 local children's hospices, and during the first 6 months of this year, neither of them were operating 24/7. One of them wasn't operating overnight at all, and the other one was only open for 4 days. We did have a very unfortunate case where a child separate to the ones that we've talked about today went to a hospice and then had to be moved to another hospice, and we really don't want that to happen, because it's not okay. One of the local hospices is now open back up to 7 days a week and 7 nights a week. So the choice is sometimes limited to either hospital or home, because we don't always have that option of a hospice. Do you want to talk a bit more about getting involved in the discussions, because you have had those?
So one of the ones that we've had is they were in intensive care, and we had discussions jointly with the hospice, with ourselves, to decide where best the child could be facilitated going home, or whether a hospice could do this. So usually we do have a discussion with all of these agencies and the consultants to decide how we can facilitate a 24-hour sort of care at home, and who can be involved in that.
And one of the challenges is making sure the parents are aware of what is on offer. So we had one instance where a child was in a local hospital, and the CCNs went over to see the child, and they were under the impression that coming home for their child's die meant that they would have a nurse 24/7 in the home with them. And the nurses had to explain that actually they're coming home to the family, and the nurses will be going in and out. So it's making sure that families know exactly what they're letting themselves in for, because it's a massive ask. And the other challenge is that we don't know. So I'm sure Dr. Irani will support me when I say that you can't preempt the time that a child can survive. You know, children are amazingly resilient. So even though they may be end of life, it could be 2 days or it could be 2 weeks. And it's trying to prepare families of, okay, well, it may be that you are managing this at home for this length of time. Does that answer your question?
Yeah, it absolutely answers my question. It's just must be very, very hard and very hard on all of you as a team just to carry on doing what you're doing. So hopefully you get all the support you guys need as well.
Thank you. We've got 3 more questions.
Sorry.
No, it's fine. This is an important topic. Julian.
Yeah, thank you. Incredibly powerful, impactful sort of presentation. Following on from Aileen there, which is how do you support the team? Because it's actually difficult. This was a difficult listen this morning. You're dealing and dealt with that number of deaths since January this year. Just briefly, what are the high-level things you do as a team to kind of stay well?
Yeah, and this is something that we need to improve. There are several strands, so the team are amazingly good at supporting each other. That's the first thing I would say. We have had some wellbeing input for the, well, guys, you're the ones that have it. You tell you, and let's say what you don't have. Be really honest.
So during providing end-of-life care at home, that's also challenging as well because it's quite emotionally draining. So we have support with the team throughout the time when we're caring for the child, as well as managers, as well as wellbeing support. Once a child passes away, we do a debrief, normally an internal one just with the community nurses. So we can obviously talk about how we think it went, and then we do a one with all agencies that were involved, so the hospital, the hospice, so a big debrief on that as well, which is quite refreshing as we can kind of air any questions or any problems we've encountered and learning points. We also have the wellbeing hub that we can contact, and I know a couple of the team have contacted them and they have been amazing. So brilliant support from the wellbeing hub.
And we always visit in pairs as well, so we're not going out alone because it can be quite sort of distressing to go out to some of these families and deal with their symptom management plan. So by going in pairs, we're there then to support one another, and then we always have a handover on our shifts that we're doing to the 2 nurses that are taking on as well, so that it's I think we've got a really good resilient team, and that we do definitely sort of talk and discuss things with each other.
Thank you very much. That's really helpful.
But I think, having said that, I think that we could do more.
Okay, and no doubt you'll let Julian know what more we can do.
Yeah. Oh no, we have plans. Yes, well, I will, but we've got plans.
Good. Well, that's great. Mark.
Hannah and the team, thanks ever so much for your presentation. It really was very powerful. There's 2 things I wanted just very briefly to touch on. First of all, you mentioned that the support to the family and the siblings can extend to weeks and months. Is there often a need where you feel that you need to liaise with the other part of Berkshire Healthcare in terms of our mental health services, in terms of the severity of the situation that some of these people are going through? And how smoothly does that transition work where you need to call upon that service?
Did you mean the support for the families with the mental health?
Yes, for the families, those dealing with the bereavement.
So we haven't actually touched base with any of the BHFT mental health support. We've actually never been aware of that, I'm afraid. And we normally guide the parents to their GP if they feel they need support for their mental health. And also the hospice provide bereavement support as well. And they have bereavement specialists who go out and speak to the families as well. So we do offer the families, parents and siblings and grandparents support from GPs and hospices.
And other charities as well. So the Child Bereavement Trust is very supportive, and also Daisy's Dream, which provides more support for the siblings as well. So I think we kind of approach more of the specialist services for that support if they need it, and usually via the GP if it's more for counselling.
And that may be because the time that the team are working with the family, it's around absolutely it's mental health issue, but it's around the specific bereavement often. And we have had 2 cases where one for rapid response where a parent had an established mental health condition, and we could see that on Rio and alerted the adult mental health team that this person had suffered a very sudden bereavement of a child at home. So that's, and then another, that was one rapid response. Another rapid response, the key worker identified that one of the parents was really struggling, and that person was referred by a GP to mental health services in BHFT. So yes, I think it's a very interesting question in terms of, I suppose the challenge for us is differentiating between a period of bereavement and meeting the needs of the bereavement, and how that then overlaps and aligns to a more significant support from mental health services.
Thank you. And just very briefly, as board members, non-executives, we get the opportunity to come out and visit services. Your service is one that I wasn't aware of, and there was a lot of information contained in your slides that you went over because of the time constraints fairly quickly. I would very much appreciate the opportunity if you were able to accommodate a visit from me, just to come and spend more time with the team, and also extend again the appreciation and sincere thanks for the work that you do. It is so valuable.
We'd be delighted to have you.
Thank you.
Thank you, Mark. Sally.
Can I ask you, and perhaps I should say that originally I was a children's nurse myself and have got some experience in this area, but it was many decades ago. But it always strikes me when I talk to children's nurses that we all look very similar, don't we? And we now live in a very multicultural society. And how you ensure that, death more than anything is very culturally sensitive, and how you ensure you're sort of sensitive to those cultural differences at this time.
Yeah, no, very good question, which I'm going to wonderfully pass to my colleagues here.
So the advanced care plan that we use is a document that obviously we created before the child goes home, and in that it addresses any cultural beliefs they have, any wishes and any rituals they want during the death or after the death, just so we can obviously make sure that we I don't know what the word is, but follow their wishes and respect their wishes. And we have if we have interpreters, if we need that in terms of making sure that the discussions, those sensitive discussions, are very clear and in their own language. So we have access to that. Any other thoughts?
I suppose it's also adapting within the home. Sometimes you might not plan for a cultural need. So with one family, they had quite a lot of family from abroad present during the COVID situation. And it was very much adapting to make sure that the situation was still safe, but that we were still meeting their needs and respecting that as a family they needed to be together.
Well, thank you. I won't prolong the discussion, but like Mark, I'd very much love to come and visit your service at some point. Thank you.
You're going to be busy.
Thank you very much, Sally. Well, Hannah and your colleagues, I guess you must realise the very high esteem we hold you and your team, and thanks for what you're doing in very difficult conditions. And I think
we'll let the rest of the team know as well, because some of them aren't here. So
please do that. And I think for me, as a lay person in this, that the balance of the sort of clinical and the personal compassion that must have to be brought together in this circumstance is really acute. And I think you do a fantastic job. So thank you very much, and thank you for Debbie for bringing it to the board's attention. So for that, we'll let you go. But thank you very much indeed. That's fine. Hannah, I don't know if you can share your screen. Oh, there we are. Well, Debbie, that was fantastic presentation. Really, really interesting. And I said this skill that these nurses have on these very difficult circumstances, and particularly acute with children, is most impressive. Do we have teams in East? I couldn't quite remember. Do we have teams in East and West, or is it just the one team?
Yeah, we do have a team in the East.
Okay, all right. In which case, well, thank you very much. Very powerful. Could we then move on to patient experience, Debbie? It's yours. 6.1.
It is, thank you. Yeah, I don't know how to follow on from that presentation, really.
It's very difficult.
But,
Everything seems rather mundane, doesn't it, after that?
It does, it absolutely does. But this is a new style report, so we're trying out a different style of report now that we are using and getting information from I Want Great Care much more. So hopefully in this you see a more balanced report that isn't just focusing on complaints, it's giving a broader range of patient experience feedback for you to be able to see. As you all know, the I Want Great Care tool does give positivity scores and star ratings out of 5, and those are comparable across all services. So a rating of 4.75, for example, in CRHT would equate to the same 4.75 in children's services. So we are able to have a bit of a benchmark across our services as well. I think it's probably fair to say at the moment we've still got variable use of the I Want Great Care tool. We are continuing month on month to see improvements in the numbers of feedback, which is brilliant. And we have got some services starting to use the feedback really well into their QI. Julie and I were visiting a ward yesterday, and it was displayed for all, including patients and visitors, to see what the scores were. They had a "you said we did" element to it. So some services are really starting to use this data, and we're continuing encouraging all services to increase their uptake and to use the data when they get it. Nothing else I wanted to say, really. Happy to take any questions.
Can I just, before I invite questions, just one of the issues with this sort of questionnaire is that you can get to a position where, you know, you're 95% positive, and so there's a danger people relax, whereas actually it's the 5% that isn't positive where the learning comes from, isn't it? And I think we're just going to be careful, you know, we don't relax because everything looks big numbers, but actually the small part that's left out can be the most important, and the learning, and it comes across in your reports. I mean, it's not a criticism, it's just one of those things that we mustn't forget. Sally.
Debbie, can you just say a few words about how we assure ourselves of the quality of the responses to the complaints, how that happens, and also the time frameworks to which, you know, whether you feel we are doing the majority of them within the required time framework, and if not, you know, how many surpass that?
Yep. So we have pretty much 98 to 100% of achieving the response, the initial acknowledgement within 3 days, and a similar response rate for within negotiated timescale. So you'll be aware that the mandated 25 days for responding disappeared, or probably pre-COVID now.
Yeah.
What we do with all our complainants is we get in touch with them and we give them a timescale for when we will be responding to them. Depending on the complexity of the complaint, that might be slightly longer than the 25 days. If there is a reason why we are not then going to meet that, we would always be back in contact with the complainants to explain and renegotiate. So that's something that we always do for all our complaints. In terms of assurance of robustness, there's an investigation undertaken. The complaints are reviewed by the clinical directors or divisional directors in the division. They then come up to Julian unless he's on leave, and in which case Alex or I see them usually. We do sometimes have questions and go back with queries, but every single one of the complaints that leaves this organisation is read by an executive director.
Well, that's essentially what I wanted. That's very assuring. Thank you very much.
Thank you, Sally. Julian.
Right, Martin, getting off mute. I just wanted to say the new report's much better. I'm sure it'll evolve, but I can see real attempts to triangulate the disparate pieces of information, whereas it was much more segmented, the previous report. Here's complaints, here's sort of compliments. And we didn't obviously have a systematic way of gathering large amounts of sort of patient feedback. So I welcome the report. I think the format is better. I think trying to triangulate it is better. I can see that efforts, and I'm sure over time we'll evolve it, but I think it's a real positive step in the right direction in terms of a more rounded patient experience report. So I welcome it.
Thank you, Julian. I agree with that. Okay, Debbie, thank you very much. Could we then move on to the Infection Prevention and Control Assurance Framework, 6.2?
Yes, and I need to start with an apology for this because I submitted it before going on holiday, and just before I went on holiday, the guidance changed again. So there are a couple of elements in this that are out of date as you see them. I have put some narrative into the executive report, which is aligned with the new guidance, but in summary, we are now following the national guidance, which removed routine lateral flow testing for staff and for patients. So we are only testing patients and staff if they are symptomatic. And then following all the usual rules around all of that. But that is a change from when this assurance framework was updated. The other change that we've gone with at the moment, which was guidance back in June, but then we had quite a lot of cases, so we didn't go with it, was that we have paused, and I've used the word pause for lateral flow and mask wearing actually, because I suspect we will see another wave and we will see increased rates and we will revert. But at the moment, routine mask wearing is not happening in any of our services, except for into our MIU urgent care, where we aren't able to triage patients before we see them. But otherwise, unless we've got cases on a ward, for example, ward staff aren't wearing masks at the moment. We're giving them a little break from that and following usual universal and transmission based infection and prevention and control precautions. But so sorry about that. Other than that, it's all correct, and I've put in red. There's nothing else to draw your attention to.
Okay, that's fine. Any questions? It's pretty clear. Mark?
Yeah, Debbie, thanks for the update. And just one question from me. I know that in the very early relaxation of the rules, there was some inconsistency in terms of application. It wasn't clear in terms of whether that was communication issue or whether it was just a general apprehensiveness from some staff who were anxious about the situation. How comfortable are you now that you have a consistent approach of these new rules being applied across the trust?
Okay, so the first thing I want to say is staff do still have choice. So if a member of staff feels that they wish to wear a mask routinely still, they are widely available for them to do so, and I would not discourage that. We have some staff that for whatever reasons, they may have, vulnerable members of family at home, they may be feel they're more vulnerable themselves. So we do have some staff that are continuing to routinely wear the mark, and from my perspective, that is fine if that's what staff feel happier doing. What we're saying is there is no requirement at the moment for routine mask wearing. So you will see, if you go round, there may well be some variation. There may still be some staff that are choosing to wear them for whatever reason.
Thank you.
Okay, thank you very much for that, Debbie. Well, now if I may move on to Quality Assurance Committee and invite Sally just to introduce the 3 items, Sally, the minutes, which I'm sure is routine, learning from deaths, and the guardians of safe working. Thank you very much, Sally.
Thank you, Martin. I'll say a few words about the minutes of the meeting on the 30th of August. As you can see, we had a presentation on the carers strategy, which is essentially a progress on the implementation of the strategy that was previously agreed. And you can see there we've had the triangle of care reaccredited with 2 stars, and essentially going forward, the idea now is to take some of the good practice which is embedded across the trust in particular services, to embed that consistently across the trust. We had presentation on the suicide prevention strategy there. Many of you will be aware, I think it was the 9th of September was National Suicide Prevention Day. And one of the issues there, which you'll notice, is identifying the learning, but picking out that one of the issues was a sort of inconsistency in assessing risk between inpatient and community services, and moving away from a sort of red, amber, green to a much more narrative approach to assessing risk. One of the major issues there, which I think will need, is a focus for the board as a whole, is the new National Patient Safety Incident Review Framework. And I won't say too much about that now, only in as much it's supposed to be a much more proportionate and considered response, but does carry, and the transition does carry a number of risks for the trust. And I know that Julian has elaborated on that in his report. A couple of annual reports around Mental Health Act Governance Committee and safeguarding, but very happy to take questions on the minutes.
Any questions from the minutes? It's very clear, I think, Sally.
Thank you.
Okay.
Learning from deaths, there's nothing outstanding in terms of the numbers, and there's been no lapses of care. And again, safe working, I think the trust is excellent around safe working, and there is nothing of note there to report.
Thank you very much. Guardian of safe working, nothing?
No.
Okay, that's fine. Any other questions for Sally while we're on the subject? Thank you very much, Sally. It looks like a very thorough meeting.
Thank you.
Thank you for that. Executive report, as usual, just take any questions anyone's got? No? Performance then, the finance report, Paul.
Thank you. So financial position to the end of July is better than we expected. So 200,000 deficit compared to where we expected to be on plan, so 400 better. Have got some challenges going into the second part of the year, which I'll come on to. In terms of year to date, we're still seeing our recruitment lagging behind where we expected it to be, which is a kind of message from the previous two meetings, and we'll need to look at what that's going to look like forecast for the remainder of this year. But we're looking at the moment 1.2 million behind pay plan overall if you take temporary staffing into account. That's obviously having a knock-on impact to our income, which is behind plan predominantly because some of the investment income we'd planned to receive we're not recognising because we haven't recruited the workforce. And non-pay broadly on plan. We're not seeing reductions in OPEs to the level that we were hoping for as part of the cost improvement programme, but what we are seeing is some benefits of increasing interest rates and capital plan phasing, which are generating higher interest payments and lower levels of depreciation. So just some key points just to pick up on since the last board. So obviously the 22-23 pay award has now been published and agreed. So all staff on AFC rates will get a minimum of 1,400 increase. Uplifts for staff range between 1.3% for those on the higher bands to 7.4% for those on the lower bands, with all bands 7 and below guaranteed minimum 4% increase. On a positive note, we had confirmation that the pay award is going to be funded centrally, which was one of the concerns that we had going into the summer, was that the higher level of pay inflation would have to be managed within existing financial envelopes. So that comes as comfort. The challenge we have is that the mechanism by which that funding is going to come down is effectively a 1.7 increase to tariff prices. Now, because of the way tariff prices are calculated nationally, mental health and community providers have a higher proportion of pay than average organisations. So funding coming down on this basis does tend to put us in a worse position than some of our acute partners. So we've flagged this to systems, and there is a proposal that will try and provide a level of equity, but at the moment we still haven't got over the line what the actual funding settlement's going to be to the organisation. So it's difficult at this stage to say what the potential pressure will be, but if it does fall down that we do get just a standard 1% tariff uplift, we'll be looking at pay pressure probably in the region of about 700,000 this financial year. Other thing probably just to raise, which won't surprise anyone, is the increase in utilities. As an NHS organisation, we are not immune to the inflationary increases, and while our increases won't be as significant as what's been seen in the press in terms of some of the acute providers who have very different energy usages given the size of their organisations, equipment, etc. Potentially we're still looking at around £1 million increase in utility prices this year, and then a further £1 million increase in utility prices next year. Now, that at the moment is based on information that our utility experts are feeding through to us. We've got to make a decision very shortly, probably by the end of this week, on what rates we lock into or not, and how long for. So we will at least have a degree of certainty based on current basket of prices, and these rates don't take into account the government's recent announcement in terms of a cap on the increases. So it could be that we see some relief to these rates, but at the moment we're not sighted on how that's going to flow through to NHS organisations. Other thing just to make the board aware of is we still haven't fully closed off the 21-22 accounts. We've still got a outstanding issue in terms of our property valuations. I spoke to our external auditors last night, and they have got a valuation that is acceptable now. So we're just working with them to finalise the audit. What it has resulted in is a secondary valuation on our PFI sites. Those valuations have come in around 30% higher than the original valuation that we were given. So there will be a knock-on impact to finance charges this year. And again, it's quite round numbers today, but that's potentially another £1 million increase in terms of capital charges moving forward. But it will mean that we can close off the accounts for last year and avoid qualification. Other thing just to note as well, which came in over the past few weeks, is reintroduction by NHSE and NHSI of agency ceiling targets. So this has been applied at a system level opposed to individual organisations, which was the previous method pre-COVID. So I think it's fair to say, and it's worth reminding the board, we are still a low user of agency staffing. And indeed the temporary staffing programme that Julian leads on, in their first tranche of work around harmonisation of rates, they couldn't actually offer us up any savings because of the rates that we were paying in our usage. So I think that needs to be taken in context. And also I think if you look at the system, there are other providers who are probably spending in a month what we spend in a year. So from a system perspective, there are other organisations where I think resources and efforts need to be targeted. But that said, we are looking at where our current agency spend is to see if there is anything that we can do to reduce rates and usage. But obviously that's in the context of our workforce position at the moment, which is challenged to say the least. Only other thing to report, which is in there, is around capital spend. We've had tenders back on most of our major estates programmes now, which have come in as expected higher than we originally anticipated given supply chain and inflationary pressures. And we're continuing to rework the programmes so that we can still come in within our allotted ICS allocation, which does mean some programmes have been slipped into next financial year. But it does mean that we will be able to complete as planned on our major estates programmes for this year, which is Fair Acres in Windsor, Place of Safety, and the movement of HQ in Bracknell. So happy to take any questions, Martin.
Well, thanks so much. In terms of my usual question about staffing and the plan, in your tables on page 153, you still show, you know, an optimistic plan or a difficult to achieve plan for the rest of the year, but that is just a plan, I understand, that we set at the beginning, so it's not we're not realistically expecting to meet that plan by the end of the year under current circumstances. Is that correct?
Yeah, I mean, I think that's fair. I mean, we set the original plan based on the assumptions of the organisation in terms of what they think to recruit, as well as playing in the investments from commissioners, which we need to show. I think it's probably safe to say that when we bring the forecast to Finance and Investment Committee and Exec Committee next month, we'll probably have a revised trajectory in terms of where we think the workforce numbers will end up this year.
Okay, thanks so much. Any other questions, please? Mark.
Paul, you touched on the capital expenditure, and in your commentary in the report, you talked about having to slip some of the projects into next year because of inflationary pressures on those tenders. But we're also at the moment £1 million behind. How confident are you that we will utilise the full capital budget this year so that we don't then start next year with all of those projects that have been slipped and an even bigger challenge ahead of us?
Confident we will spend. Some of the delays have been holding off some of the smaller projects because we knew that we would have to do a level of reprioritisation. So I think given some of those big projects are coming in at higher cost, we'll fully utilise the allocation this year.
Thank you.
Okay, anything else? Paul, thank you very much. We'll to challenging times, but thank you for your work. Can we move on to performance report 8.1, please?
Yeah, thank you. So just to note, you'll have a look when you see some of the breakthrough objectives. We've started to bring in some SPC charts following the board presentation, and we'll continue to do development on those over the coming months, including if we need to make any revisions to our business rules. Just to pick up on some of the highlights in terms of the driver metrics, falls 2 months better than target, which is encouraging, but obviously we need to see if that trend continues before we can make a view on whether we've had any meaningful shift in performance. A lot of work still going. We're getting closer to a single technology solution across the organisation, which has been tested at the moment and is getting positive feedback. And we've developed an e-learning platform around falls, which is gone onto our intranet, which again is really positive step in terms of reducing the fall numbers. Physical health checks behind plan, but acknowledging we've made great strides in this, and that final push getting up to 90-95% was always going to be difficult. We're doing some targeted work in the Slough area, including rapid improvement events, to try and increase rates there, and we're getting good engagement on the ground to do that. Debbie's already mentioned in a report I Want Great Care, which positive score is higher than target, which is good, and despite it flagging red, obviously we are seeing increased response rates month on month now, which is encouraging. And the final one I just wanted to flag was staff turnover, which, although it's showing red for the last 4 months, it's actually, we've seen 7 months of increase in terms of our turnover figures, and we're 2.5% higher than we were at this point last year, which is kind of bearing out what's happening nationally, which is, you know, seeing the highest level of vacancies across the NHS that have been recorded. I think Jane and her team are continuing to work hard in terms of bringing new recruits in through the front door, overseas recruitment, apprenticeships, and also looking at streamlining our recruitment and onboarding processes. And in terms of retention, they just completed a 2-day rapid improvement event last week to look at how we can make improvements to staff retention. So difficult area, but a lot of work going on to see what we can do. Happy to take any further questions.
Any questions for Paul? Sally? And then Mark? Sally? You're on mute, Sally.
Do beg your pardon. Paul, we might not be able to answer this because it's around self-harm on Snowdrop and Bluebell. There's been an increase in self-harm, and I wondered whether it's probably Debbie or Minu who might be able to answer this one in terms of how it correlates with other things. For example, you often get increase in self-harm if there's less opportunities for activities for service users or staffing issues, whether we've looked at these or whether we're, it might just be a month on increase and it's a blip, as it were.
I'll take that if you like, Paul. So we quite often find, Sally, that it is linked to individuals, and depending on individuals on wards that we see this, but there is active work going on within Prospect Park which looks at this for all individuals, and it will be part of their safety plan, as well as part of the overall review of this as a breakthrough objective, but it's normally linked to individuals being admitted.
Yeah, Debbie, sometimes when it's individuals, you can put in brackets 1 times 15. Do you know, it makes it clearer sometimes, but that's a separate conversation.
Okay, thank you for that. Oh, sorry, yeah. Debbie.
I was just going to say, we did have that for a period of time because we had the number of people that it was impacting, didn't we, showing underneath. I don't know if there's a reason why that was stopped, but we did have that for a period for all of our breakthrough metrics, actually.
We can look to, I think we spoke to Ian about looking to reintroduce that. I think there's a bit of a technical difficulty trying to get it onto the chart at the moment, but we can look at doing that because it did add good context in terms of the number of individuals that were driving that number.
Okay, thank you, Sally. Mark?
All our average length of stay for mental health inpatients remains resolutely high, and it has been for some time. I was encouraged to see that in your narrative you talk of an improvement project is underway, and I just wondered whether or not, when some progress has been made with that, whether an update report could be given to FIP at a future meeting, just to give us an understanding and some assurance in terms of the work that's being done on that very difficult issue.
Yeah, we can do that.
Thank you.
Sally, you've got your hand up again, have you or not? No? Okay. Thank you very much. Thank you, Paul, for that. I think in terms of the format, I think it'd be useful to just reflect on what's the appropriate detail to come to the board, because there's a danger we could just add and add and add, and some of that is best handled through FIP, I think, but we just need to reflect on that, I think. Okay, can we move on to finance, the FIP itself? Naomi is not able to be here today, but we have at least one item for ratification by the board, which is the new terms of reference. Has anyone got any objections to ratifying the new terms of reference? Thank you very, very much. Has anyone got any comments on the FIP papers at all? Okay. Oh, sorry, Sally.
I was a bit slow there. The only thing I'd say about the new terms of reference is that when you look at recruitment and retention, it's obviously very holistic, and it's beyond looking at the numbers, and clearly other elements of trying to increase, for example, retention relate around a lot of the staff welfare issues or career progression. And I just put I suppose I have a slight sort of concern that that there will be other elements that we will want to look at elsewhere that will also enhance, particularly.
You're on mute, Sally.
Will enhance particularly retention.
Yeah, well, I think we understand the complexity of this problem, but if you've got a concern, perhaps talk to Naomi. And okay, can we then move on to Res?
Thanks,
Alex?
Martin. I'll just introduce. So this is the annual Workforce Race Equality Standard. report for noting and the Workforce Disability Equality Standard for noting. We have Amit Popat here and Jane, and I think Amit is going to just do an overview of both. Is that right, Amit?
That's right.
Welcome to the board.
Thank you so much. It's my first board. Jane, we've just had a conversation. Was there anything else that you wanted to mention before I launch into my very brief presentation?
Really, yes, just to explain a little bit context around Amit and Amit's role here. As you know, Amit joined us on an interim basis, and one of the key roles Amit has had is in, really testing what we are doing here as an organisation. We know, for example, you'll all have seen the RES and WDES data. We're not making as much progress as we would like in some of those areas. We are making some progress in some things, particularly in the WDES, and Amit's expertise we brought in really to have a good look at what we are doing and what could we do differently, to try and turn the dial on some of the data that we're seeing and some of the experiences that lie behind that data. So I'm going to pass over to Amit and then let him talk through a little bit of the summary of the report, and then happy to answer any questions about what we're doing, what we may not be doing, and give you a better feel for the work that we're focused on here.
Amit, thank you. You can assume we've read the details, so if you can just bring out the highlights.
I was just about to say that I've assumed that you've read those papers. Wonderful. So I'll skip by some of these slides, which I hope you can see. Can I just get a thumbs up from someone that you can see the slides as I'm moving on? Great, fantastic. So essentially, this is the data which you have in full information in your packs. And essentially, this is what we're noting for the different areas of race and disability. So this is the area of race, as Jane has already highlighted and mentioned, that we are still seeing some disparities, and I'm sure the board will be keen to try and understand about how we're trying to fix some of the problems that we're facing. So I'm going to be moving on to some of the solutions that we've created for the organisation. This is the DES data as well, and there's some disparities there that we need to note and we need to understand. For the DES, we are already part of a disability confident accreditation. So that's really positive because it gives us a very structured approach to be looking at particular issues around disability for the organisation. For the race equality issues, we are going to be, and I'm going to be touching on this as well in the solutions bit. We are going to be thinking about trying to create an appropriate, proportionate anti-racist strategy approach for the organisation in line with the emerging new EDI objectives that we're creating for the Trust. So these are the programs that are addressing the disparities which are currently in place. So we've started to share interview questions in advance, which improves the recruitment experience of disabled and BAME staff. So we've noted that that has had a positive impact on people through the recruitment process in the organisation. In July 2022, we've launched the neurodiversity strategy, which supports people from certain disability groups who are associated with neurodiversity. We've launched, our Deputy CEO here, Alex, has launched a fair recruitment guidance in September 2022, and a video has been produced to link to that. We've achieved, as I've mentioned, our disability confident accreditation in March 2022. So we can see that these things are already in place for the organisation. What's in progress are what I featured here from 5 to 10. I'm not going to read each out, but I'd like you to just take a quick glance on screen. So having joined in May, so it's been around 5 months since I've joined the Trust, there are things still in progress with the organisation, and these are the areas which we hope are going to solve some of the particular challenges that we're facing, particularly around the experiences of BAME staff. We are going to be doing some deep dives, as mentioned, to try and really identify what the issues are and find some resolutions in line with an anti-racist approach. So I'm happy to take any questions.
Okay. Amit, could I just, the board is absolutely committed to this agenda, and we have been as long as I've been associated with it, certainly I'm sure before. One of the things that always slightly worried me in the past has been a sort of a rather generalised approach to some of these issues.
Yeah.
And my experience elsewhere tells me that we need the way to do it is actually to focus and solve a problem so that staff who are affected can see the problem has been solved, or at least made better. And my reading of these slides in the paper is that that's the approach that you're recommending, that sort of more targeted, more focused approach.
Yes.
Is that a correct assumption?
That's a very correct assumption and a right assumption to make. Yeah.
Okay.
That's
Thank
right.
you. Thank you very much for that, Sally.
I'd just say that I'd agree with Martin there. I think you have to be very much led by the numbers, you know, and be focused and look at good practice and elsewhere as well. But what I wanted to ask was, do you feel that I'm building on what Martin's just said? This really has to be led by the board. And I just wondered, as a non-exec, if there's anything you think that we could do as non-execs to be seen to be right behind this.
Well, that's a very good question and a very good point. Of course, if we look at all of the EDI practice in line with excellent and best practice, it's always been around top down. So what can the leadership in the organization actually do to drive change? There are some competency frameworks, and I'm not sure whether they are competency frameworks or just frameworks around best ED&I practice for boards. And it was something I was just looking into the other day around whether that's something that the board could adopt. So we can consider that as an option and propose it to the board moving forward with the new emerging objectives we're creating. If that's something that the board would be happy to consider, then that would certainly raise the profile of the board's engagement with EDI practice.
I'm sure, Amit, I'm sorry speaking over you, Sally, but I'm sure we'll be pleased to hear. Maybe you can let me know what you think we can do. We've tried to do, you know, take this very seriously with taking on sort of mentoring people from different backgrounds and having people talk to us about their experience, real life experience from staff. But anything, you know, you can help us guide, because we want to get traction and really get to the bottom of this problem. Sally, is there anything else you want to say?
No, thank you. Just look forward to meeting you at some point, Amrit.
Mutual. Thank you, Sally.
Rajiv.
Hey, Amit. Thanks for all the data. So I can see lots of indicators that we're using to show the differing experiences of people from the BAME community versus, say, white community.
Yeah.
How are we assuring ourselves that within the BAME communities there isn't a disparate experience between various members of those communities?
Yeah, and historic and current data actually shows us across different sectors that there is. So we might have to dig a bit deeper around the particular issues, and just taking on Martin's particular point around being targeted. So the reviews that we're going to be doing, which are going to be a bit of a deep dive into the experiences of BAME staff in the organisation, that will then highlight for us if there's disparities across the different groups and demographics across BAME. So, and I don't want to be overly presumptuous, but from my experience working in different sectors, we find a difference between Asian Indian groups compared to Black African. So there's something there that we might need to address particularly for the organisation. Yeah.
Very good. Thank you.
Julian.
Thanks, Sammy. Good morning. Just yeah, with the benefit of fresh eyes and your experience, obviously working elsewhere, since sort of May, can you perhaps identify one area that you've been encouraged by in relation to the Trust and Sagenda, and one area where you thought, you know, there's a good springboard for improvement here. There's an improvement opportunity here. Just give us a flavour of those early insights. Maybe something that's been encouraging and something that's perhaps you thought, okay, these guys need to pretty much improve a bit here.
So I'll touch on two things on each side, and the encouraging aspect from a cultural perspective
Amit, do you want to take your slide down and then we can see you better?
Oh, okay. Not sure whether that's a good idea, but anyway, there we go. I'll take it down. All right, good. Can you see me now better?
Yeah,
is that all right? Okay, good. All right. Where was I? My flow of thinking was. So the encouraging thing is the conversations I've been having across the organizations around a thirst to actually see change. So there's definitely an appetite for the organization to say we need to change on this, which is really good, because then we can lead into that in terms of programs, activities, training, etc. there's a sense of the culture being potentially conflict avoidance. So that's something that I feel that I've come across, which is why we're having a solution for that, which is a dispute resolution framework. So there's something about really trying to avoid some of the more challenging and difficult issues around ED&I when we really get down to discrimination. So there's something there that we're going to need. So we need to kind of balance out that thirst with maybe a bit of fear in the organization around actually dealing with some of the hard issues of ED&I. So that's something that we need to consider. Another positive has been the work around the engagement, for example, with Pride. We had over 85 volunteers within the space of 3.5 weeks of organizing and planning that event, and a high footfall presence of people really engaging with the public, and lots of people who are from LGBT groups within the trust and who are not, who are allies, sponsors, really showing commitment to the agenda. So I think that there's really good practice there that we can utilize for across the different areas of ED&I. So I think there's a thirst, there's engagement, there's something else, and I'm going to take a liberty here, Julian, and that's around our community engagement. I think our emerging ED&I strategies really needs to have better community engagement there with faith community organizations, other voluntary sector groups who can really co-create some of the work for the organization. So I think there's more work to be done there.
Amit, thank you very much. We have spoken briefly, haven't we, before this meeting? And just to say to colleagues, I thought a very positive experience talking to you, Amit. So
thank you.
I think that the approach you're bringing to the trust will help us make some real progress. And I'm absolutely convinced the whole of the board is really desperate to, do our best to sort this out. But a bit of guidance or professional guidance would be very valuable.
Great. I'm here until January from an interim basis, and I've been here for 5 months. So I'm going to do my best to support you as much as I can by that date. All right.
So there's no leave for you until after January, at least.
Let's see.
Amit, thank you very much. Thank you very much indeed.
Thank you, everyone. Thank you.
Jane, did you want to add anything, or Alex?
No? Not from my side, no.
Okay.
No, helpful discussion. Thank you.
Yes, thank you.
Great. Thank you.
Thank you. Bye-bye.
Thanks. Bye-bye.
Okay. In which case we'll move on to the audit committee. Oh, sorry. Quality status report and key trust initiatives 9.2, Alex.
As for noting, please, colleagues, and happy to take any questions.
No. Okay, that's fine. So if we move on to audit committee, and Rajiv, back to you.
Yes, nothing particular to comment on from this audit committee. I think the bulk of the discussion was around the external auditor signing off of the accounts. Paul just touched on the issue that we have there, and it's almost resolved. So happy to take any questions from the minutes. Oh, there was a very small change to the terms of reference, just cosmetic more than anything.
I think we probably have to formally ratify that. So I'm sure we have just done it. Any questions for Rajiv? No. Okay. In which case, schedule of meetings, just for information. Council of Governors update. The governors are looking again at the Living Life to the Full group, and Tom Lake has taken on sort of acting chair and trying to work out what to do about that following John Barrett's retirement from the governors, but all positive. And we have the AGM, of course, coming up face to face. So I've got nothing else to add on that. Any other business? Date of the next board is the 8th of November. And before I close the meeting, can I invite any of our observers to ask a question if you have one? Don't have